My first slide gives you a brief overview of the UK health system. We've got a population of just under 64 million, and we spend each year about £147 billion. We're doing well on life expectancy, and that's very positive. And I've got a slide that shows what's happening to mortality rates. How are we doing with my slides? Mortality rates have been decreasing. Age standardised mortality has been coming down for many, many years, largely due to cardiovascular disease. So that's great. If you look at a lot of the outcome measures in the UK, it's improving. So you missed my picture of Big Ben. The point about the picture of Big Ben is it's taken from the Treasury, an illustration that NICE does engage not just with the health service, but with the central finance within government to talk about how we allocate resources. This is my slide about mortality, doing very well. That's going down. This is the amount we spend on health, which went up for many years when we had a Labour government. Now the funding is flat. The red lines are public funding. We do have a small amount of private healthcare too. But the point is it's flat funding now in a context of inflation. So a lot of pressure on the funding in our healthcare system. And that's alongside the increasing demand for healthcare. A lot of unhealthy habits, too many people smoking, too many people are obese. We've got lots of people now with chronic conditions. 70% of our budget is spent on long-term chronic conditions. And people have higher expectations of what they should get. So it's a tricky picture. Thinking about what we've been doing in the UK to manage all those pressures, there are some specific things that have been about driving efficiency in how we spend money. So some of that's quite practical, national drives to make sure we procure the best deal, say, for surgical equipment. We've been doing a lot of work in hospitals to decrease waste. So we've been doing those practical things. We've also been tracking more recently, and I'll show you a slide at the end, the variation that we still have and how we might deal with that. And of course, there's NICE's role. So just a few slides about how NICE fits into that. Our key role within the system is to provide a national reference point. So it's national reference point, providing guidance and standards, and that's advice on what works, what's safe, and what's good value for money. And we've been in existence since 1999 and are now seen as a key resource that ensures we've got that national reference point. And what we do in looking for value for money is that interface between evidence and guidance. It's not a straightforward translation. It requires lots of input from experts and stakeholder groups, and there's no straightforward algorithm. Pretty in a sort of most fundamental way, there's no cut-off value. But if you see that green box at the bottom, most of the things that cost less than £20,000 per quality adjusted life year are considered good value for money. Then there's a bit more uncertainty, and we need some flexibility in the decision making. So there's no absolute threshold. You'll see those little crosses down there in the green box. And that's just to point out that we don't just look at cost effectiveness of new drugs and new technologies. We also look at public health prevention interventions as well. And those are all things that come from the public health programme as an illustration that prevention can be a lot more cost effective than the treatments at the other end of the spectrum. So we look at cost effectiveness. We also look at how much that is going to cost the health system. In many cases, although things are cost effective, they do add costs. Where we can, we find things that will actually save money. And we have a programme that looks at new medical technologies specifically with that brief to find out where new technologies will really save money. And as you might expect, more often than not, they don't. They might add better care. They might add more accurate diagnoses, but the actual saving of cash out of the system is not that easy to do. As well as cost-effective advice and guidance, we also set quality standards, so standards that are designed to drive up quality. If that's the quality curve, the quality standards are very much about pushing the curve to the right and driving up quality. And we've got quality standards across a whole set of pathways, 180 pathways. And the purpose of showing this is to remind you that this is what we're trying to do. We're trying to drive up quality of care in that financial environment that I showed you earlier, with the flat cash going into the system, yet an ever-increasing demand to drive up quality. So it's all rather challenging. So efficiency and making the most of the resources that we have is absolutely essential. I said earlier that we're looking at variation. This comes from something called the Atlas of Variation that we've been publishing in England over the past few years. This is about care. It's about a package of care, and it shows how it clearly varies across the country. I could have shown you a slide that's about uptake of new drugs. I could have shown you a slide about hip surgery. I could have shown you a slide about mortality rates. They would all show variation. And I guess some variation is always going to be inevitable because human beings vary. But the reason why we're focusing on variation is to make sure that we're not overspending, that we're not undertreating. It might be inappropriate in both directions. So we publish this, and we then expect people at a local level to really dig deep and find out what the reasons are and what's justified and what isn't. And my final slide, a saying that I like to use quite often: change is not made without inconvenience, even from worse to better. Said quite a long time ago by a vicar outside at Exeter Cathedral in the south of England. And the point of this is to emphasize that it isn't easy to change things. Even if it's going to be better and more efficient, it's quite resource intensive to get yourself there. And I think we need to remember that as we drive our health systems to be more efficient, we're on the hamster wheel. If we don't give ourselves sufficient capacity, sufficient slack, it won't be possible to improve things. You need to have some space and some resources to make improvements. And I'll stop there so I don't overrun my time. Thank you.
Thank you very much, Gillian. In the interest of the fact we started a few minutes late, I'm just going to press on now, if that's okay. I'd like to go now to Josep from the Belgian National Health and Disability Insurance. Hello, Joe. Just please, you have the floor for 5-10 minutes. And
okay.
Please.
There's no slide deck. There's no risk to... it's safer. General remark. Some years ago we were in Tallinn, and there was a famous charter which was approved, charter which was launching the idea of performant health systems. Last year we were in Vilnius with a declaration, and now we are in Riga. I don't know what will be the outcome, but we cannot do it for less than for a real action plan in which we are favoring for health inequities. And let's be clear, health inequities are unnecessary, unjust, but more avoidable than we think. But nevertheless, it's much easier to gain a broad agreement on the need for health inequities to be reduced than it's to deliver coherent policies that achieve this aim. And it's clear for all of us which are involved directly in health policy that, of course, we need a portfolio of instruments and tools to capture these problems. And healthy lives must be a reality for everyone not just for the wealthiest. And let's explain a little bit what we have done in Belgium. Last year we have our organization, our health scheme was 50 years. And at that occasion we take some very important initiatives to evaluate our system. It was not health technology assessment, but it was an evaluation together with population and together with specific groups, for instance, the Doctors of the World, in which we have made a green book and also a white paper in order to tackle this huge problem of inequalities. And of course this session is tackling the problem, can efficiency collaborate and improve solidarity, or is efficiency a measure of affecting solidarity? And of course it's a thin line on which we should be aware that linear measures which increase co-payments and other things are increasing of course inequalities. But of course we can take measures which support solidarity and which decrease these inequalities. And what we have done was a dialogue with citizens, what we have called citizens labs, in which these discussions came clearly on the table, and also with the Doctors of the World, as I mentioned already. And of this discussion, 6 actions came as an outcome. The first thing was to increase the awareness of the health professionals to the problematic of health inequities. We think that all our doctors and all our health professionals are aware of that. No, when you see the distribution of health professionals, you can see that they are looking for the wealthy cities and for the wealthy countries. How can we in fact stimulate and increase not only the awareness but also the support of the more vulnerable groups? Secondly, what we have seen also, that although we have a health system and a social security system which is well known and which is estimated very high by our proper population, we can see that a lot of risk groups are confronted with health problems. Thirdly, the organization of our health systems. Is our health system in itself not a barrier for health equalities? And we see that, for instance, administrative barriers, but also the payment methods and provider payment schemes can be an effective barrier for access to our health schemes, and therefore we promoted also the generalization of a third payment scheme and prepayment scheme. Prevention and promotion for specific categories, and we all know the publications of Sir Michael Marmot, but the avoiding risk in pregnancy and delivery, it's a very important thing, and an action plan was set out on that, also drug users and so on. What we have seen also, and was a specific claim of this Doctors of the World, was to create intermediate structures to include persons into the health schemes. We have the doctors and the patients, but we have intermediates, guides in one sense or another, which can guiding people through the health systems. It has to do, of course, with health literacy, which was already mentioned today, but it has also mentioned with aid of people with specific problems, I think, on mental health and so on. And we should be more proactive in our health systems. We are visiting a doctor and visiting at the hospital. We should be more proactive and searching where the problems are and going right to these groups. And a last action point, which was already concretized, is to, and it's linked with the former point, it's to increase capacity of what we are calling patient advocates and intercultural mediators, which are sitting in the hospitals in order to translate a little bit and to make bridges between patients and health professionals. What we have done and what we are doing now for the moment is integrate these people also in our health administration and have patient advocates in our health systems in order to evaluate at the floor if the measures we are taking are appropriate or not, or are lacking some of these things. This was a very original action plan. A second thing is now put in place and to do with pregnancy and delivery. Yes, I will finalize my intervention, is of course reducing length of stay in hospitals. And one of the things which was put forward was pregnancy. But there was an alarm, and health impact assessment said, okay, be aware that of course people at risk and prematurity is a very unequal distributed risk. Let's try to put in place health policy which has an holistic view and which can integrate this problem. Last point on, and I will come back later on in the discussion, last point is what can Europe do? And of course I think at the European field a lot of things can be done. This morning the health commissioner and the health minister, president of the council, has already mentioned a lot of actions. But I think one of particular attention is the access of medicines. What I'm always astonished what I see when I see that. In fact, we are talking a lot about inequalities, but nevertheless the gaps are widening. Earlier this year, Professor Alger published in The Lancet a multi-country analysis about the health status of adolescents in Europe, Canada, and the United States, in which it was clearly stressed that these gaps are widening. So is the case also in life in pharmaceuticals and in life-saving drugs. And I think the council conclusions which were taken last December in favor of bringing innovation to the benefit of the patients need more action, but I come back to that in our debate. I thank you.
Thank you very much, Jo. Adrian, we now, please, thank you. Yes. We now move to Adrian van der Hove of EGA. Adrian, please, the floor is yours.
Thank you very much. I'll try and accelerate this process a little bit to make sure that we have enough time for a healthy discussion. So it's really a great pleasure to be here today to participate both as a speaker and a partner in the conference. I'm going to take you through some of the roles that our industry plays in terms of improving access to healthcare, but also go through some of the challenges that we're facing and see how we can work together to solve some of those challenges. So first thing, just to highlight to you that actually the mission statement of our industry association is to deliver sustainable access to high quality medicines to all European patients. So this fits well with today's program as well. This mission is pursued through a 5-pillar strategy which informs everything that our association does. And this 5-pillar strategy, as you can see, is around patients. Of course, we are the largest providers of medicines, around quality, value, sustainability, and partnership. And today's conference is really very much about the last pillar of that mission that we have, which is about partnership. And that's why we're really proud to be part of this group today. So one of the things that probably you don't know so much about the EGA is we are actually 3 sectors of medicines manufacturing. We are the generic sector, which is the largest volume of our business. We are increasingly the biosimilars producers as well, because we have been on the market now for 9 years, and this is obviously taking off at the moment. And we have a third sector, which is called value-added medicines, which is about our contribution to sustainable innovation in the sector. One of my colleagues, who's the chair of that, will be presenting later, so I don't want to take all of his thunder away. So I'm going to talk a little bit about access and why generic medicines play such a key role. This looks at many chronic disease areas that you can consider, whether it's cardiovascular, diabetes, mental health, where generic medicines really play a fundamental role. And what you can see on this slide is really the increase in access, 100% increase in access in Europe over a 10-year period, thanks to the contribution, the competition driven by generic medicines. Obviously fundamental for European healthcare, really the backbone of medicine's delivery. But of course, it's not just about access, it's also looking at outcomes. And here we've looked, for instance, in the area of hypertension to see what kind of difference this makes in terms of health outcomes. And you can see here, the estimate according to this study is 1.6 million quality years saved thanks to the use of generic medicines in hypertension, where millions, close to 50 million patients are treated. If we look at diabetes, and I asked the question earlier on, the majority of patients in Europe with diabetes, which as we know is unfortunately an increasing chronic condition in Europe, are treated with generic medicines. One of the key challenges for us is the sustainability of the market for these generic products. And this is really important for patients as well, if you consider, with respect to adherence, what the effect of copayment can be for patients. So here you see really the important role we play in generic medicines, but there's also a link to how the market is structured and what this means for individual patients. Biosimilar medicines, you'll see much more about this in the news today with monoclonal antibodies coming to the market now for biosimilar medicines. But actually, this is not something new. Europe now has 9 years of experience with biosimilar medicines on the market. The access benefits in terms of access to biotherapeutics is huge. And here we have the access for filgrastim, which is a treatment used for neutropenia, often for cancer patients, for instance, chemotherapy patients. And what you can see for biosimilar filgrastim is that you have had an increase in patient access by 44%. It's significantly higher in some countries than others. But what this probably means, we have to of course verify this, is that there's much more medically appropriate earlier use going on there, which is obviously a beneficial thing for patients. And it's really the competition from biosimilar medicines that has driven this change. And I'm convinced that we'll see much more of this across other biotherapeutic areas as well in the future. Now, to summarize, what does our industry provide to the healthcare system? I think we try to break it down and look at different facets of this. So obviously the most important point is to increase equitable access, and I think you can see fundamentally for many European countries where access is still a major issue for medicines, our industry is delivering that access. This is particularly the case in poorer European countries, but it's also, as you saw from our previous slides, also in Western European countries we see usage rates go up significantly thanks to biosimilar or generic medicines. What does this mean? It's not really about savings, it's about better health outcomes. It's about treating more patients. This is what our industry is supposed to do, and I believe this is what we are delivering. Now, in terms of healthcare systems, what are we providing? Well, I think this is very fundamental for the sustainability of healthcare systems. So just one number, the IMS just did a study on generic medicines where they showed that without generic medicines to treat the same number of people, it would cost healthcare systems across Europe another 100 billion euros. So that just gives you an indication of what this would mean not to have generic medicines in there. Obviously, fundamentally important is healthcare systems are designed in Europe to provide universal access. I think that would be impossible without generic medicines. I think in the future it will be impossible without biosimilar medicines as well. Now for healthcare professionals, I think this is also a fundamental point to underline. I think what our medicines provide is really more options. So by driving competition, lowering the price point, doctors have more options, medically appropriate earlier use, changes to protocols, etc. We see this happening with the introduction of our medicines, and this is really fundamental for healthcare in the future. Now, I've painted a very rosy picture of the delivery, I believe, from our sector, but we are facing major challenges currently on our industry. So the first major challenge is the predictability of pricing. Obviously, we are multi-source products, which means there are many generic or biosimilar companies competing around the same molecule. So we are there to drive competition, including price competition, and that's perfectly normal. However, what we see increasingly is due to the introduction of very high-priced medicines, for instance, for hepatitis C treatments recently, we see government-mandated price cuts being introduced widely across Europe, pushing the price of our medicines to unsustainably low levels. What does this mean in practice? It means that sometimes our companies withdraw from some markets, which means that either patients don't get access to that medicine or they have to go for a higher priced originator medicine in that case. In countries with co-payments, for example, that leads to adherence issues in practice. So this is something that really needs to be thought through. Another key issue is administrative burdens to EU regulatory systems. So we are not asking for the removal of EU regulations. Actually, we are the strongest and staunchest supporters of high standard EU regulations. We promote this globally for generic and biosimilar medicines in countries with less regulated markets. We are big fans of the EU high standard approach. However, we do face a problem that there is essentially a problem with the harmonized implementation, and we continually face what we would call administrative duplication requirements at national level in many of the EU procedures that we follow through. And this is redundant, it's not bringing benefits to patients, and often it's wasting the time of national regulatory agencies. So we think here we can apply the same high standards in a much more efficient way. Finally, we still face structural barriers to competition for our markets. There's still a huge space for generic medicines to grow in many countries in Europe. We see with biosimilar medicines that most biopharmaceutical markets are not at all adapted to competition from biosimilars. We have to go market by market to really get rid of those barriers and enable competition to take place. So these are some things that could be examined at a European and a national level, I think, to bring more sustainability for our industry, but fundamentally more sustainability for patients and healthcare systems. To summarize, our industry is committed to deliver more to improve equality of access to healthcare, to improve health outcomes. We believe, as all the other partners around this table, that there needs to be more investment in healthcare, both in terms of concrete investment in pharmaceuticals, but also at looking at investing in efficiency of healthcare systems. And we think there's a lot that can be achieved here. And we think that this should be done in partnership as we're doing it here today at the conference. Thank you.
Thank you very much, Adrian. I'm now going to pass the floor to Josep, or excuse me, from Josep Figueras. Forgive me, Josep.
I'd rather be you.
There he is. Josep, please, the floor is yours.
Jo has already raised many of the issues I want to put on the table. I am particularly fascinated about the actual question you put for this session, Duane. Preventing health inequalities by investing in efficient health systems. So, can we have the cake and eat it?
Are they mutually exclusive?
Are they mutually exclusive? Can we have both? I think that's the key question, one of the key questions that I think we should raise. So are efficiency measures redistributive? If we redistribute, are we more efficient as a society? And I think the first question that I think is interesting to thresh out is how we measure costs and benefits. A lot of the economic evaluation of interventions is based on healthcare costs. And that effect undermine interventions for efficiency, because if we measure the impact on the society, on productivity, on societal cohesion, or if we include, much more complex of course, the issues about human suffering, many of these economic evaluations will come up with very different results. So it depends as well, how do we measure efficiency and how do we measure the costs and the benefits, economic or not, of these measures. I think it's fair to say that many redistributive interventions tend to increase efficiency, in the sense that it is in the poorer social classes, in the vulnerable groups, where we have the highest burden of disease. Therefore, those interventions aimed at those populations are bound to have a higher rate of return, in the sense of getting better outcomes, but not always the case. I'll come back to that in a second. It's not the other way around in all cases, though. In efficiency cases, particularly if you look at the technical and allocative efficiency, not to go into economics jargon, but if you look at the technical efficiency, which is what worries hospital managers, this is, I do my product at the lower cost. That doesn't mean that this efficiency will be redistributive. It all depends on the access to that product. And to be a bit devil's advocate, mHealth is a good example of that. mHealth, in many instances, mobile health apps, will increase efficiency, but if it's not got accompanied by literacy measures, access measures, mobile health will not actually be redistributed, be the opposite. I'm not saying that we should have equity in poverty. This is because mobile health does not, the lower social classes may not access that, may not have the literacy to do that, therefore no one should access to it. I'm not saying that. But I'm saying that in pure technical efficiency terms, which what moves many managers, doesn't mean that actually you are redistributive. Of course, if you could look at this more on a health gain kind of perspective, allocative efficiency, then you can see that many measures devoted to improving the health gain of the overall society are bound to benefit all social classes and the poorest ones. There's another issue there which is interesting, of course. Waste and inefficiency will never be redistributive because the less resources you have, the less opportunity you have to redistribute those. So that's an interesting element. Anyway, going into the practicalities, again, as we already heard from the generics medicines approach and the approaches that were said by our colleagues today, that there are many interventions where you can see that you have both the cake and eat it. I think it's worth talking about the health systems access and the whole move on universal health coverage and user charges. Universal health coverage is not only about equity. One of the main rationales for universal health coverage is efficiency. The Obamacare, the real rationale for it is being efficiency, not only access. We know how expensive they are. Let's take an example in our continent. How expensive it is to get refugees or illegal migrants not to access primary care. Because ultimately, we'll have to take care of them when they reach our hospitals, would be much more expensive. So many of these measures, and here I would like to echo what Josep was saying, during the financial crisis, we saw those countries that were successful, those countries which actually improve access to the vulnerable groups. Take Belgium and the decrease of user charges. While many countries increase user charges, some others like Belgium targeted those vulnerable groups to reduce user charges. These are the people you want to access the system. These are the people that won't suffer the most. In actual fact, it's interesting, there's been a lot of debate whether the financial crisis has increased mortality or not. And overall numbers, you don't see that. But when you look at the vulnerable groups, you see the real impact of the financial crisis. So the clever countries and policymakers have done these kinds of equity measures that have resulted on efficiencies because you got access to those who are suffering the most. The question, though, there is I'd like to ask this question, Johan, and I don't want to take over the moderation, but take patient advocates. I mean, when you get patient advocates, you get more access, and therefore you get more equity. If you looked at that purely on economic efficiency terms, it's quite expensive to get the access to this population. In terms of return, on pure health service terms, if you look at the overall society. So this is when the issues become interesting, because the way, I repeat this point, the way that our managers and many policymakers look at it is from a purely technical efficient perspective. Just to finish, many other interventions that have been already measured here, obviously primary health care is highly progressive. This is an area where access to primary health care will be a redistributive factor. And then I'd like to say a couple of points on public health. Most public health measures, health and all policies measures, will have a redistributive element to the extent that many of these risk factors are more present in certain vulnerable social class groups. However, when we talk about the screening, it's the same situation. So you want to do programs to reach these more vulnerable populations, but it's much more expensive and much more complex. So are we prepared to add, I'm getting there.
Sure.
Are we prepared to add these additional resources to capture and involve these populations? If we don't do that, I mean, I remember years ago, it's many years ago, Gillian, in the UK when the GPs were provided an economic incentive to do cervical screenings. And this is many years ago, because I do believe that the UK is a full front of many developments. At that point, they got lots of incentives by doing a screening to the same type of population. Women of high social class would have many cervical screenings, one after the other, but of course you didn't deal with the burden of disease. It's gone a long way, you're now paying by outcomes, it's gone very far in the other direction. But what I was saying here is there is an interesting element there. And I'm going to finish there, just to give you a step to the next speaker. That's an area on the health literacy, actually, where you can have the cake and eat it. Health literacy is an area where you actually see improvements in efficiency and you see improvements in equity as well.
Thank you. What I want to get into with you later, though, is that there's also a question of the person who pays now might not be the person who gets the benefit. And it's how you measure that, because someone is investing in primary care, it might be the city or somewhere else down the value chain that's actually reaping the benefit 5, 10, 15 years down the road, but that's not politically expedient. But we'll get into that.
And that's the question of inclusive growth.
Yes, yes.
And there is one element there, I need to say this one, it's very important. Economic evaluation discounts benefits in future very highly.
Mm-hmm.
It's one of the problems we have. For instance, we did some work recently about evaluating the economics of prevention. And one of the issues is that economists have this bad habit to discount the benefits in future, which I'm not sure that they reflect actually the values of society. May reflect the values of politicians of short-termism,
yes.
Not all of them, fortunately, but not those of society.
We'll get into this later. I think that's a key point. And now I want to pass to Stanimir. Thank you very much.
Thank you. I hope my presentation will be on now, yeah.
We've matched the learning curve, Stanimir.
Yeah. It's really nice to be here, actually, following the Vilnius conference. And I'm really glad that one of the best evaluated outcomes after the conference there was that we have improved in collaboration. And actually, the Patient Access Partnership is clear example of collaboration between the different stakeholders, as the conference today also involving the variety of the stakeholders. For those of you who don't know what's the Patient Access Partnership, it's kind of direct follow-up after the Vilnius conference and the declaration adopted there. It's a joint initiative led by the European Patients Forum and the Patients Organization in Bulgaria, but it is a multi-stakeholder platform to facilitate the dialogue between patients, European policymakers and institutions, healthcare professionals, member states, industry, and other stakeholders. Why? Of course, to find solutions to improve access, to improve outcomes of the healthcare systems. The internet site of the Patient Access Partnership is now live, so you can visit and understand more there about the partners, about the work streams, about the topics that are within the discussion and the debate of the variety of the partners on European level. I will start with a thought that probably you know very well. It's coming from a person who is meant to be the father of the modern management. This is Peter Drucker. You can't manage what you can't measure. And kind of second part of this thought, if you can't measure something, you can't improve it. So is this really valid when we talk about access? Can we really measure access? And can we really improve access? If we can't measure it properly, can we really manage this situation and improve it in a better way? Because at the end of the day, when we talk about access and healthcare systems outcomes, I think we all have to remember the focus why we are talking about that. And it's about the patients. It's about the patients who live in different parts of UK, and we saw how different is the picture is there. It's about patients who live in different parts of Europe, and we can show so many examples of patients who are really in equal situation and chance to get access to good and better healthcare. So coming back to the measurement, one of the things that we should consider, actually, what do we measure? How do we define access? And within the Patient Access Partnership, this was one of the first topics to be discussed within the partners. So now the partners agreed on, we call it the 5 A's principle for explaining what's access. The 5 A's principles actually is based on literature review, on available definitions of access, but I think it describes very well different elements of what we call access. So the first A is availability of services, how available are products. The second A is how adequate are they? Are they adequate to the needs? Are they adequate to the highest possible standards for patients? Are they accessible? Can we really get them when we need them? Are they appropriate? according to guidelines, appropriate according to needs? Are they affordable? Can we really pay for that? So these 5 A's became the principle of what the Access Partnership considers to be access right now. And you will see later in my presentation, we are trying to verify how well these 5 A's would help us to explain access and help us to measure access in a way if we want to really manage and improve access in Europe. Then, to the next topic, how can we measure access objectively? This was a topic of one of the work streams of the Patient Access Partnership called Mapping Access in Europe. So currently, there is a questionnaire developed with the help of some academia, and I'm really happy that some academia from Greek universities helped a lot, who have done good amount of work during the crisis in Greece and how it affected changes in access in their countries. And I guess after today they will have much more work to do. This questionnaire actually is focusing on different elements of a healthcare system, like primary care, hospital care, medicines, medical devices, and so on and so on. Each of the elements of the healthcare system is evaluated under the 5A principles. You will have that idea after I present the first results that we got end of last week there. But each of the elements of the system is evaluated, how affordable it is, how accessible it is, etc., etc., etc. The questionnaire is rolled out currently to the stakeholders on national level. So it tries to involve the same stakeholders as those involved in the Patient Access Partnership on European level, but on national level. So the questionnaire goes to the patient groups in a country, the healthcare professionals associations, industry associations, public health organizations in each of the countries. Currently, we are in validation phase of the questionnaire with 3 pilot countries, Romania, France, and Cyprus. And for these 3 countries, we have collected up to now more than 30% of the questions only for a few days. But I can tell you that some of the results are really surprising. So now I'm going to show you kind of a flash of our findings in these 3 countries. The questionnaire aims to go afterwards to all EU 28 countries after the validation phase. So, just a very small result. This is one question that we are asking, evaluating secondary healthcare services such as long-term management of chronic diseases and access to them. And here you will see some of the answers of different stakeholders. The first one I want to present is coming from Cyprus. How accessible are these healthcare services in the country? So you can see here that the healthcare providers disagree that this type of healthcare services are accessible in the country. So basically they say they are not accessible. Unlike a pharma industry association that actually thinks that these services are quite accessible in the country. Is this always the case? Let us go to France. We have some answers showing that sometimes a patient organization, for example, and pharmaceutical association could agree on a topic. And actually in France, in most of the answers, it's more or less close, the answers coming from the variety of the stakeholders, but it's not always the case, like here, about the affordability and how adequate are these services in France. Let us go to another question. Here we try to evaluate access to patented medicines in these 3 countries. So again, they were asked how adequate is the access to patented medicines, how affordable, appropriate, available, etc. And here we have also some very interesting results. For example, starting with Cyprus, you can see again, 2 stakeholder groups, the healthcare providers, the healthcare professionals, this is the Doctors Association, who disagree. They think that access to patented medicines in this country is not sufficient. And then we have an industry association who agrees on this topic. I'm finishing. This is the last slide.
Thank you.
Then, let us go to France. Another result from France. The two groups disagree and have two opposite answers. But let us focus here on a very interesting result coming from Romania. If you see the answer from the patients, they actually, for all 5 elements, strongly disagree or disagree concerning access to patented medicines. And then the result from the Pharmaceutical Association really surprised me. Actually, they strongly agree or agree that access to patented medicines is very good, actually, in Romania. And then I started thinking, oh my God, this is a country where for 7 years access to innovation have been restricted, only few new medicines have been approved there. And when I started looking into the survey and the questionnaire, guess what? This was actually the answer from the Generic Industry Association. So even within the industry, there is difference of perception of access. The conclusions on that, if we cannot improve access in Europe, if we cannot measure access properly in Europe. Perception for access is totally different depending on who you are. Measuring access precisely would require the view of all stakeholders in the healthcare system. We cannot simply take what the government says or what the industry says, or even within the industry, who in the industry says that. And last but not least, I would say we have to improve the current indicators probably, or we have to think of new indicators that would involve all these elements and stakeholders inside in order to have comprehensive evidence-based tool to measure access and to be able to overcome with some of the problems in access. Thank you very much.
Thank you. Thank you very much, Stanimir. I suppose I should let Adrian respond to Stanimir's question that he's posed. Do you have a comment, Adrian?
Well, actually, I'm glad that Stanimir put that on the agenda, and it highlights the need for better dialogue between our industry associations and patient organizations. Actually, with Stan, we have, in a way, together with the EPF, also initiated this. I think it's also interesting to point out the challenges that there are in Romania, and the challenges in particular with access to new innovation. I mentioned it. We know hepatitis C is a major problem in that country, also a major issue related to the socioeconomic conditions and a variety of issues related to that. We also know that essentially the pharmaceutical sick fund is inadequate to cover that. And I think what happens basically is that as these products will be introduced at some point, there will be just a big chunk of the sick fund budget that will disappear. What does that mean in practice? It means in practice that either some generic products will be withdrawn from the market or the co-payment will have to increase to cover that cost. In a market like Romania, where the co-payment makes a big difference to people's personal bottom line, personal salary situation, that will lead to people basically no longer adhering. So I mentioned, for instance, there's a big problem with diabetes, oral diabetes generic drugs in Romania or Bulgaria. And what happens then, those people then subsequently have to go to the hospital, have to get on a new treatment, which again will be typically, well, they'll move to a higher level of treatment, which probably be a branded product. Again, takes money out of the sick fund. So it's a vicious cycle. And then you get to a very difficult situation where you say, okay, are we going to deny access to, for instance, hepatitis C products in a population that really needs it, to sacrifice another patient population which also really needs to adhere to their treatment? And we're coming up with this kind of dilemma. Now, this is an extreme example, unfortunately, in a country with a very limited sick fund budget. But as we know, roughly, and it's the same case in Bulgaria, roughly in September, the sick fund budget runs dry. You have to have an emergency budget bill and all this kind of stuff every single year. This is the situation here. So we need to look at this, and we can't sacrifice one group of patients for another. We need to find a balanced approach that takes care of all patients. And as an industry association, we are in favor of access to the best treatment for patients, whether it's the drugs that our companies produce or the drugs that Richard's member companies produce. We're in favor of this. But in this kind of situation, it becomes intractable. And I think that
probably explains that divergence of views there for the patient organization and the generic pharmaceutical industry.
Thank you. Do you have a quick comment?
Yeah, I don't think that the result shows controversy between patients and the industry, not at all. But this question clearly shows that the perception of what is good and what is wrong is totally different depending who you are and from which side you sit. And I think the learning from this is we have to find a way, really, what you just said, to find solutions that work for everyone and to acknowledge what's going on from the point of view of everyone. Otherwise, we are not able really to measure, we are not able to improve. That's why we have to think of new ways, really, to know exactly what's the situation in a country or in a region or a particular element of the healthcare system. And I really wonder what the results would be when we have the results from EU28, from all stakeholders, from all countries. Then we will be probably surprised. And this is not the case only with industry, with industry and patients. On this question, I'm sure we will have it in many other cases, like the doctors and the patients say completely different things about the same element in the same country of the healthcare system.
So I want to move on. I'd like to have the survey questions pulled up so we can use that as a platform for our initial discussion. So I'd like to bring up the first question of the survey. I'd like all of you to grab your little survey gadgets and gizmos, please. That's a technical term. And again, these are statements from a roadmap that we're putting together, which will be presented tomorrow. And these statements on a scale of 1 to 5, 1 being strongly disagree, and 5 being strongly agree. So we're going to start piecemealing these one at a time. We'll begin with the first question now. Implement the principles prevention, promotion, and protection as core principles for health and all policies at the European level. A very simple question. There we go. Please, strongly disagree, agree, neutral, strongly agree. So this is obviously asking a lot of the helicopter view of what we're trying to do in the session today. Be interesting to see how this comes out. No priming from the dais, please. Thank you. Thank you. So where are we at with this? Strongly agree, I think. That's quite good. This goes quite well to what we were just discussing. Now, actually, Joe, I wanted to get into something you mentioned about prevention, promotion, and protection. And you used effective solidarity was a term that you called. But I'm wondering about that in the context of Belgium. Belgium's a very interesting country because Flanders is extremely wealthy, but yet under development rules, there's second area development in southern Belgium. Some of there's areas of where a separate country would qualify for aid. How do you, at the insurance, balance those competing interests? How do you balance those things?
I don't think there is a healthy divide between the north and the south as such. What we see is there is a healthy divide in the center. Mm-hmm. And when we look to our figures in Belgium, we see that, for instance, in the capital of Europe, Brussels, we see that there is less uptake in medical services. There's no primary care there. There's hospital-oriented care. And what we are focusing now on these great and big cities in which we have to develop more actions because we are confronted with more isolated persons, we are confronted with aging persons, we are confronted with cultural barriers and so on. And this context is, of course, very interpelling the health insurers and our health insurance, and we see that clearly in the figures. Also, when you go to preventative measures and so on, the uptake of participation to preventive campaigns of breast cancer and so on. You can of course there are differences, but there are differences between north, south and so on, but we are focusing now on a second element in which was coming out of our citizen labs, that we should be aware also by two things: the inverse care law, which is saying, okay, that high skilled and high technical medical interventions are of course not redistributive but contra-distributive. And Josep mentioned already M-Health, that's one element, but you can make the same thing for genetic counseling. You can make other remarks on that. We should be aware of that we are tackling sufficiently the equal use, not of access in the scheme, but going into the details. Also, second element is not the inverse care law, but is the inequity by disease. We are focusing too much on some diseases, and some of policymakers are not sufficient oriented anymore to this basic structure of large access, which is redistributive, and a health system as such should be redistributive. And I think that's very important also in this economic tough times that we... and last remark I want to make about prevention and cost. Of course, it's very difficult to measure sunk costs, and there's the indirect profits. They are never accounted, and accounting this in terms of profits is a very difficult one, but I'm very convinced that investments in cost-effective prevention, of course, not in prevention as such, but in cost-effective preventive measures could save a lot of healthy life years.
And that actually is a good lead, because that actually goes into our next survey question. So if we could have that up, please. Identify appropriate and smarter ways of preventing unnecessary costs to the system in health and economic terms while promoting health across all stages of life. This relates very well to what you just said, Joe. This could be done by, for instance, implementing cost-effective preventative measures such as smoking bans, effective food and alcohol information to consumers, promotional physical activity, and vaccination. So strongly agree, strongly disagree, strongly agree, strongly disagree, folks. That's quite a long question. I think we covered just about everything there. Everyone getting their votes in? And what do we have for results? I imagine this will be yes. One person strongly disagrees. There's a libertarian in the audience. So if we're looking at this from the prevention, smoking bans, is this considered low-hanging fruit? What do you think? Is this easy to do? Is this what we should do? Gillian, you're nodding.
Well, in the UK, we've been tracking improvements in health since the smoking ban came in, and I think it's fair to say that everybody is actually staggered by the improvement that did result. I think everybody knew it would make a difference, but the impact it's had and the speed of that impact has outweighed any people's expectations. So if there are any countries that haven't instituted it, far more cost effective than some of the other things that we put in place before, simply to encourage people to stop smoking.
Okay, we're going to take the next survey question, please. Continue to raise awareness regarding antibiotic resistance and promote initiatives addressing the issue being antibiotic resistance. Any comments here on this? Let's see how we do here. Again, we have one person sort of, we have one troll, ladies and gentlemen. We have one internet troll. That's right. So what
is the confidentiality of this?
we could probably hack into it, Josep, if we really wanted to and find out. So I guess I'm going to talk to the HTA folks here now, and Josep. What about a vaccine? What about a vaccine antibiotic? That's going to be more expensive, but could potentially be more effective. What about that? What about working in vaccination for antibiotic resistance? What do you think of that? Anyone want to, would that be a good thing, bad thing? Would there be support for it? It would be very expensive to develop, but potentially the health outcomes long-term could be better. This gets back to our point on short-term versus long-term cost and discounting. What do you think, Josep?
To me?
Yes, you.
Again, I go back to the issue about how you measure the impact of these measures, the long-term impact of these measures. In principle, I believe it would indeed pay off in terms of the additional benefits. I don't know much what's the research on this area. Actually, I'm surprised by it. I heard something, but I didn't know that was a kind of measure you can already debate in these kinds of forums. But if you go to the much better known issue about hepatitis treatment now, clearly it's a very good case where the long-term benefits are huge when you do economic evaluation analysis. So if we talked about the similar sort of dimensions, certainly would be value for money.
Okay. We're going to move on to the next survey question, please, so we don't run out of time. We did start late. Develop an effective health promotion and disease prevention agenda. This should include efforts to strengthen the role of healthcare professionals, since healthcare workers play a fundamental role in educating their patients and promoting health literacy. This goes to Stanimir's presentation. So again, strongly disagree, strongly agree. And Stanimir, do you see this being an important part of the mission that you folks are trying to roll out with your survey? Yes? Sure. Yes. Still one troll. Yes.
Josep.
Who's doing this?
We need debate, don't we?
Yes, please, Gillian.
I don't have a vote, so it's definitely not me. I forgot.
Well, we're not blaming you, Gillian. That's fine.
But I would have voted yes. But we have to remember, don't we, that health promotion, education initiatives tend to increase inequalities because they are most directed and taken up by those more affluent in society. So it's not enough on its own.
Yeah, on the other hand, actually, this is a great tool to empower patients. And we have to understand with the comorbidity, with the chronic diseases becoming really more prominent, we cannot surround that. We have to invest that. We have to empower the patient in order to have the patient on the side of the healthcare professional and really supporting and contributing and producing health rather than being the cost in the healthcare system.
Adrian, you wanted to jump in.
But,
nope.
I just wanted to just add a point here. We've had some experience recently with biosimilars and efforts by both the Commission and the European Medicines Agency at a more European level, but also individual member states at a more regional, local hospital level, if you wish, really engaging with stakeholders, medical doctors, patient groups. And that has been really positive experience for us. It was something relatively new for our association to engage so directly with patient association, but it's really been a positive development to encourage countries at the time of introduction of new biosimilar medicines, and it's something we would really continue to advise because it's really been successful.
Two brief reactions. The role of healthcare professionals, you can see them separately or you can see them as a whole, and I think the important thing is to integrate them, and that's a huge effort to make, and of course e-health and other tools can promote that. Second element, I think we should also think about the remuneration of our health providers, because financial incentives can of course also have a huge impact on the way your healthcare is delivered. And thirdly, okay, be aware that some of your healthcare professionals should be have also professional information to tackle these problems, to tackle the problems of mental health and so on. One of our primary care doctors associations said, okay, we need support to tackle these problems. We can do it, or we have two options, or we are prescribing antidepressants, or we are trying to assist our patients, but we are not paid for. And of course, it's our paradoxes we should find a solution for.
Okay. Next survey question, please. Support a policy shift from a cost focus in the European semester or other like initiatives to an outcomes focus, tackling notably healthcare inefficiencies, to prevent disease and avoidable health deterioration while addressing health inequalities. Again, ladies and gentlemen, please vote. I'm sure we'll have one person strongly disagreeing, just on point of troll principle, and we'll see how everything else goes. Outcomes measures. See how we do. Again, pretty much quite a large percentage of the people going for strongly agree. So how do we put in outcomes measurements? How do we do that broadly across Europe? Is that easy to do? Can we do that across all EU 28, compare and contrast? Josep, what do you think?
I think it's difficult to disagree with all these questions.
Although someone is, I'd like to point out, someone is finding the ability.
I'm not sure what's the objective here. But I'll disagree a little bit. Just, well, it's not cost really. It's about value for money, isn't it? It's about cost and outcomes. And it's all very nice to say we want health outcomes and quality, but we know about limited resources, and we know that our ministers of finance do have to struggle between health and education and many other sectors. In fact, if we're talking about the use of resources during times of crisis, I'd rather put them in my own country, Spain, on proroguing the unemployment benefits and the healthcare system. So we should be a bit cautious about saying, yeah, the semester is going to work on outcomes, because it's never going to be the case. So it's much more about how we move those kinds of decisions on those areas that are more cost effective. And actually the semester has started doing some of that. I am quite optimistic, perhaps against everybody else, but I'm very optimistic about some of the measures we've seen in the semester, like strengthening primary health care in some countries. I've seen these recommendations. The worry, however, is, I'm going to your question finally, is that in fact the kinds of measures that our colleagues have there in ECFIN and elsewhere, and we have elsewhere, are quite limited about being able to actually measure and compare the performance of these different areas. So we still are a long way to be able to use that. But just trying to disagree with everybody, I don't quite agree that you can only change things that you can measure. So, because sometimes too much, so contradicting myself, we should not put all our eggs in measuring, because we do know that some things are not working even if we cannot measure them. So we have enough evidence without having to spend lots of money. Measuring costs money as well. Measuring, you can spend your life measuring and not being able to make any change. So all in all is to say, we do know what areas are more efficient. The semesters are looking at them. We need to measure better, but not to be too obsessive about measuring and measuring only.
Because I have to respond on that. Measuring.
I just want to provoke you.
That's very good, actually. Measuring just for the measure doesn't help. But measuring to identify gaps, barriers, as you said, we want to look where the difficulties of the local authorities, this is what we need. We need to know where the gaps and barriers in order to be able to be effective in what we do and what policies we introduce. So measuring for the measuring doesn't help. We will be kind of, and we don't need such measures. We need measures that actually could change lives and patients. And just for the semester process, I think that it's very important, and I've seen how the semester has helped governments to do some changes. Like next week we are having a meeting in Sofia with the Commission focusing on the semester in support of the reform that the Bulgarian government is trying to do there. But what's also very important to be acknowledged, the cost. We cannot simply turn and not focus about the cost. For many governments, it's not about value, it's about affordability. And when the cost is really high and unaffordable for a government, then we are in a big trouble. Therefore, you and some other experts for a couple of years now are working, can we introduce more fair pricing system in Europe? So we have to think about those things as well. Value is fantastic, but when you can't afford value, it simply doesn't help to have it there on paper.
And someone else. Yeah. Adrian, you wanted to come
We've been engaged around this EU semester process and quite supportive of many of the aspects. I think there's a lot of opportunity here to introduce greater efficiency into the system. I think what we have to be extremely careful, though, is just cutting costs can mean just not treating people. And that, in our society, where in the end people have to be treated in a hospital setting or something, will just lead to more costs or more people getting sick or sicker, which is something we shouldn't do. So it should be about being more efficient. I think this is what the health semester should be. Second thing is, I think sometimes there needs to be additional measuring. So when it comes to pharmaceuticals, in some countries there are clawback measures, for instance. The clawback measures are not integrated into the pricing, the cost assessments of pharmaceuticals. So of course the cost of pharmaceuticals seems to be going up, even though you have a clawback, bringing it down, because it's not integrated into the statistics of most international statistics bodies like the OECD and others. And so you get skewed statistics. So I think also sometimes there needs to be a little bit more measurement to make sure we know what we're talking about.
Okay. Yes, coming back to the European semester, of course, what we should do also is not only formulate recommendations, but also see what is the impact of the recommendations. And second thing, together with the other member states and the European Commission, I think the initiative of the health systems performance assessment can also be effective. But I think that on the field of inequalities, we should be very more precise and setting targets and measuring that. What we have now as indicators in the SILC system, I think is too general, and I'm in favor of more practical tools and more practical systems. For instance, I have promoted already the access to medicines index to see what's the uptake in the different countries and what can be, for instance, factors who explain these huge differences. I think one of the missions of the European member states and European Commission is to be very clear that the gaps in health inequalities are not widening. We are pleading in favor of reducing, but be aware that in some cases we are widening these inequalities, and we should be very aware of that and measuring this very clearly.
Now we're going to go to the final survey question, and then I realize we started a little late, so we'll probably allow a few questions. Member states in the European Union should establish the process of early dialogue and joint advice to meet specific characteristics of precision and personalized medicine in order to guarantee that available treatments are accessible in all member states. So the accessibility of all cutting-edge medicines, please vote now. So we'll get the results. We're all over the map on this one. The troll has some friends. Okay. Is early dialogue enough? Is that going to get it done? Is that the problem, early dialogue, or is it something else? Stanimir, what do you think?
Early dialogue is important. I would say not only about personalized medicine, but to all elements of the healthcare sector. The dialogue is very important. But coming to the personalized medicines, we know the price, the cost is going to be really high. And I don't think that only dialogue could help in this situation. So it's absolutely valid for personalized medicine because we know what the price is going to be. And I'm really afraid that at a certain point it could create more inequalities in some parts of Europe rather than assuring access. So I think we are coming to a point when we have to be innovative in thinking how we assure access, how we change the system in order to assure access, to make products, services more affordable and linked to actually the ability of a government, a society, or a patient to pay for that. And this is really, really important.
Yeah, a lot of people want to get in. Gillian, I want to go to you.
Just to say clearly, early dialogue is important, but it is going to be a complex change that requires some thinking around the methodology to assess how the personalised medicine should be fed into a health technology assessment programme, because it's not going to be the way that we do it now. And the high cost might be right if it's genuinely personalised and the numbers are lower, but it might not apply. And then there's the services and the whole range of things that need to change.
Sure. Another Joe.
I think the early dialogue is very important. Once we're going through this process of HTA, I think the question is formulated in a way that you say available train, that existing treatments are available, and it's about existing cost-effective treatments are available. But the issue is, after we have this HTA in place, is the kinds of how do we integrate that into health system, into primary health care, into specialized care, how is it paid for? So there are many issues that we keep ignoring in terms of regulating, integrating it, paying for it, and so on. I think that's where the early dialogue is very much needed, because these measures, these mechanisms are hitting the market, are hitting the consultations of the GPs, and we don't have any mechanism to deal with those.
This is a conference at its own, personalized medicine, and I think Luxembourg presidency will organize something like that. But early dialogue with who?
Yes.
This, of course, it's not a question of market authorization, it's also a question of pricing and coming to the market and integration of these products in the health schemes. And therefore we are in favor, of course, to have an integrated approach, not only on the fact of market authorization, which is a very clear European competence, not only on the field of health technology assessment, in which there are already early dialogues organized, but also on the field of pricing and by doing horizon scanning. And why not cooperation between member states, not, and let's be very clear, not in order to organize procurements or joint procurements, but trying to think together to this future, because this is not business as usual. It will announce a new era, and we have to prepare ourselves on this new period. I think it's very important.
Sure. That, how much horizon scanning is actually going on right now in the Council?
Horizon scanning in the Council?
Because you mentioned you need to do horizon scanning for basically what sort of innovation is coming, what impact
the
that
fact
will be
that
on
we are
pricing.
confronted
What is
with
the horizon scanning going on?
That will be a proposal which is coming on the table, put by some member countries, and on the 15th of July we will see in the working party on senior level what if there is agreement on that to organize that together with other countries and supported by the European Commission. But the fact that we didn't do any horizon scanning as was confronted in 2014 with the Hep C and all these panic reactions and so on. Let's be prepared. I think everybody aims to be in a stable climate in order to get also able to prepare this health system in an appropriate way and to see what's in for Europe, not for one country. And this effort is a great effort to try to have more cooperation on this field, which was traditional a field of every member states separately.
Now we started a little late, so I'd like to open the floor just to a few questions, please. So we have a question here. Yes. Please say your name and where you're from.
Yeah, Boris is from MSD. I was just thinking that horizon scanning can go both ways, because right now we're thinking about it, and there are initiatives towards that in order to inform healthcare systems of what's coming. But at the same time, we see, in particular in the HCV field, right now there's a standard of care, and there's one product, one company. So in terms of improving efficiency, what would be the role of more competition? Because basically my company is bringing a product that is going to be extremely competitive with the Gilead's product. But at the same time, we know that, for example, in the US, this product got this faster approval process mechanism. In Europe, it's not so sure. We'll know later on during the next months. But then we know that the pricing and reimbursement systems, most of them start only when we have marketing approval, sometimes taking more than a year, if not more. So there is really right now, between horizon scanning and looking at what the competition is bringing, an opportunity for a lot of healthcare systems to actually generate savings for products that are highly efficacious.
Any comment on that? Nope.
I just comment that actually similar things should be reflected upon for not from a regulatory point of view, but from a pricing reimbursement point of view for biosimilar medicines, for example, to once they're approved through the centralized process, we don't think there should be any changes there, but there should be a reflection by member states on how to get those products into the market more quickly so that you could have more competition in biopharmaceutical space, similar sort of thinking.
Another question, yes.
Idea. It's more of a comment. My name is Richard Bergström. I'm head of FPN, one of the proud sponsors next to Adrian of this meeting. No, I agree with what you just said, Adrian. This is not only about the innovative new medicines, it's about biosimilars. And it's also about technology in general, science in general, which may be more long-term. So we have all these horizon scanning units. I think in the UK you have some really good people that do these reports, but we don't act on them. And this is what we've all learned over the last year, is that the sudden arrival of breakthrough medicines in hepatitis C has now resulted, I think, in quite constructive dialogues at the country level. So in fact, during the lunch break today, FPA signed a letter of intent with the Minister of Health for Latvia, Guntis Belevic, that you saw this morning, to set up mechanisms like this for Latvia, including, and this is in the paper, the ambition to have models where we get paid for outcomes. So pay for performance. Now, that's easier said than done. Duane, you asked the question before. But we're committed as an industry with a number of governments, and Latvia is not the only one. We are in negotiations with both Romania, Bulgaria, Slovakia right now about similar arrangements. So this is coming. So something positive has come out of the brouhaha in 2014, as I think you said, Joe. Thank you.
And one final question, then we're going to let people have coffee. So, yes.
John Kakia from Malta. Can I take this back to the patient, please? In Malta, in my office, we tried to understand the population that we're serving. So we commissioned the National Statistics Office to produce a health literacy survey of the Maltese population. If you want copies of this or contacts, give me your cards and I'll send you paper copies or soft copies. What are the findings? Because if we go back to the patients and see what they are telling us about health systems, patients in Malta are telling us, we do understand what you're trying to offer us in service terms, but health promotion, disease prevention are not coming to us clear. We're understanding the health screening messages, but we're understanding less and less about mental health. And there are conflicting messages between what the professionals tell us and what social media tell us. What are the reliable social media, internet-based information services that really give me good advice? Who are the reliable ones? So when one discusses this on a quality basis, what we've tried to do in this survey, and I can discuss this later if you would like to, we've tried to identify who are the vulnerable ones for health literacy. And we're trying to push this debate towards a one-to-one relationship between health professional and patient, because that is where the interface on literacy should happen. But that means...
Can you just please get to your questions?
I'm coming to the final statement.
Thank you.
On a one-to-one basis, it's understanding what the person in front of you and his or her literacy issues are to try and come directly to the issue of their health and hence addressing inequalities. It's good to have policies in place, but those policies must sustain a one-to-one relationship at the professional service level, which really addresses the equality issues on an individual basis. Thank you.
Thank you. Yes.
Just a couple of things on that, because it's a really important point. Two things. One is a lot of work that NICE is leading in the UK in relation to shared decision making, to really make a sort of a proper collaboration between the professional and the patient. And the interesting bit is what information should underpin that, how much detail in terms of benefits and risks, and because people vary, what sort of format. There is not going to be one answer. There's going to need to be flexible ways of presenting information, I think. That's one thing. And the second is social media. It's lots of apps, all sorts of things that are appearing on phones, providing information. And we've been thinking about, should that be accredited? Should somebody give it a stamp of approval? But it's so difficult because there are so many of them. And actually for years we've had patient information in magazines and books, and we've not worried about accrediting it. So there's a real interesting dialogue going on about how you do that, or if you do it.
I'd love to go on. I would. I think they want coffee. And there's a troll out there we need to track down. So I just want to say thank you very much to the panel. I'd like to thank you all for your questions and your patience. I thought it was a very good discussion. And so we'll have a coffee break, and we'll be back in about 20 minutes or so. Thank you very much.